Welcome to the Tobacco Online Policy Seminar, TOPS. Thank you for joining us today. I'm Michael Pesco, a professor of economics at the University of Missouri. TOPS is organized by myself, C. Sheng at The Ohio State University, Michael Darden at Johns Hopkins University, Jamie Hartman-Boyce at University of Massachusetts Amherst, and Justin White at Boston University. The seminar will be 1 hour with questions from the moderator and discussant. The audience may pose questions and comments in the Q&A panel, and the moderator will draw from these questions and comments in conversation with the presenter. Please review the guidelines on tobaccopolicy.org for acceptable questions. Please keep the questions professional and related to the research being discussed. Questions that meet the seminar series guidelines will be shared with the presenter afterwards, even if they are not read aloud. Your questions are very much appreciated. This presentation is being video recorded and will be made available along with presentation slides on the TOPS website, tobaccopolicy.org. I will turn the presentation over to today's moderator, C. Sheng from The Ohio State University, to introduce our speaker.
Thank you. Today, we continue our winter 2026 season with a grand rounds presentation by Angela Wu entitled The Role of Clinicians in Supporting Smoking Cessation for Individuals with Cardiovascular Disease and Mental Illness. This presentation was selected via a competitive review process by submission through the TOPS website. Dr. Angela Defeng Wu is a senior researcher and lecturer at the University of Oxford's Nuffield Department of Primary Care Health Sciences, where she works with the Oxford Tobacco Addiction Group and the Center for Evidence-Based Medicine. Her research focuses on smoking cessation in underserved populations, particularly in relation to mental health and cardiovascular disease. She applies psychological and anthropological perspectives to examine how health behaviors are shaped by social, structural, and environmental contexts. Her Doctor of Philosophy research investigated the impact of smoking cessation on cardiovascular and mental health outcomes, as well as the prevalence and delivery of smoking cessation support in primary care. Her current work evaluates the integration of brief smoking cessation advice into financial support services and the development of interventions for people living in social housing. Dr. Jamie Hartman-Boyce is a co-author of these studies and will help answer questions in the Q&A. Dr. Wu, thank you for presenting for us today.
Thank you so much for having me. So let me just share my screen and then we can get started. So hopefully everyone can see that.
We can see the next slide. So you can, if you can change the presentation mode.
You can only see presenter mode, is that correct?
Yeah, I'm seeing presenter mode.
Okay, that's no worries. Let me come out of high presenter view and we can just go from this viewpoint. That's fine. Okay, well, thank you so much for having me today. Before we get started, I just want to state that the funding source for this piece of work was from the British Heart Foundation, and I have no conflicts to declare and no tobacco-related funding sources. Now, to put a little bit of context into who I am and how I found my way into tobacco research, during my undergraduate, I worked at a hospital in the hepatitis C clinic, and one of the questions and avenues that I had to do was work with patients to ask them about their smoking. And one patient told me that they had started smoking at the age of 4 and that their parent had given them their first cigarette. Now, this to a naive undergraduate student was quite a shocking moment, and it really made me think about how do we look at health and health behaviors and what do we think is choice? And really, the big question is, what does choice mean when it comes to health? And I hold on to that, and we'll talk a little bit about the concept of choice throughout this presentation today. Now, cardiovascular disease causes about 30% of deaths worldwide, and tobacco is a key risk factor, and we know that quitting can prevent both first-time, and there's more and more evidence to suggest that it can also prevent future cardiac events. Now, in a 2016 paper looking at people in Europe, they found that 8,000 people who had experienced a cardiovascular disease event, about 26% of them were smoking. Now, following these patients 6 months later, 61% of them were still smoking. Now, of these participants and of these patients, the majority of them had been prescribed ACE inhibitors, statins, and beta blockers, which are common medicinal avenues to help people prevent secondary cardiovascular disease. But only 19% of them had been advised to attend a stop smoking clinic. And of those 19%, only 20% of those who attended were offered any medication to help support them to stop smoking. Now, flipping onto the other side of the coin of my research is looking at people living with mental illness. Now, 1 in 8 people live with mental illness in the world. And what we know is that people with serious mental illness typically die 15 to 20 years sooner. And the reason for this earlier death is because of smoking, or smoking is one of the leading contributors for these preventable physical illnesses. And then that raises that question of inequalities, of are we furthering health inequalities by allowing people who are still with serious mental illness to continue smoking if it is decreasing their life expectancy by 15 to 20 years? Now, in the UK, we have seen a fantastic result in terms of decrease of overall smoking rates. So we're seeing the smoking rate go down from about 46% in the 1970s to 12.9% in 2022. But if you take a deeper look into who is still remaining within that 12.9%, we see a slightly different picture. Within the UK, these numbers have not decreased for people living with mental illness. And currently, about 85% of people living with schizophrenia are smoking. Now, why might that be? There are some potential reasons for this, in that many people, both in the general population and people living with psychiatric disorders, they state that they use smoking to cope with their stress, and about 40% of people believe that smoking helps them to relieve stress. And this fear of mental health decline often deters people from quitting, as well as it can deter clinicians from offering smoking cessation support to both the general population and people living with psychiatric disorders for this fear of mental health decline. But there seems to be evidence to show that quitting is actually associated with an improved mental health. Now, looking at these two categories of individuals, they're not separate, it's deliberate. These are two groups that seem to have a lot to gain from smoking cessation, and yet are also the populations that seem to not be being offered smoking cessation as an intervention. And this is where my PhD and the work I'm presenting today kind of sits. So the aims of my PhD was to look at the extent and rate of harm reduction when someone stops smoking, to also look at smoking cessation treatments that are being offered and the effectiveness of them, and finally to take a look at how can we motivate the gatekeepers or the providers, the physicians, to intervene and offer smoking cessation support. Now that split itself into 4 different projects that we'll do a whirlwind tour today of the 4 projects. So first off was looking at smoking cessation for secondary prevention of cardiovascular disease. And this was done in the form of a systematic review, which was an update of a 2003 Cochrane review. And what we had found was that people with heart disease who smoke, they had about a 30% reduction of risk of having a second cardiovascular disease if they stopped smoking compared to if they continued smoking. And while we did find heterogeneity within our meta-analyses, this was not to do with the direction of effect, but rather the magnitude of that effect, which gives us relative certainty over the evidence that stopping smoking can help people who are living with cardiovascular disease, help them reduce their risk of having a second event. And additionally, on top of the outcomes of looking at absolute outcomes like mortality, looking at deaths due to cardiovascular disease events, as well as MACE, so major adverse cardiovascular events, we also added in a new outcome, which was looking at quality of life. And what we found was that smoking cessation was unlikely to worsen your quality of life and may improve your quality of life. So that was the first project, which is published with Cochrane. And then in the second study, what I looked at to also look at the harm reduction was looking at smoking cessation for mental health, a secondary data analysis of randomized control trial. And this was working with data from the EAGLES trial, which is one of the largest trials looking at smoking cessation and the effects with people living both with and without psychiatric disorders. And now our goal initially was to try and solidify a little bit more about the causality of smoking cessation on the effects of mental health. And we had three different strategies, and we included typical regression models as well as propensity score matching and instrumental variable analysis. However, our instrumental variable analysis was severely underpowered and was unlikely to detect any results. But what we did find was that generally people who stopped smoking had a decrease in their score, which meant that their mental health, in terms of their anxiety and depression scales, improved. So they had an overall better feeling after stopping smoking. And what we did find was that when we focused particularly on people living with psychiatric disorders, they saw a greater reduction. So they saw a greater benefit to stopping smoking when it came to their absolute numbers of their anxiety and depression scores. But again, although the original goal was to run an instrumental variable analysis, which could hopefully help us solidify the causality of this, given that we can't randomize people into smoking or not smoking, and because it was severely underpowered, we're unable to detect whether or not there was a meaningful difference. But the other two analyses did point towards the direction that stopping smoking helped people in terms of their mental health outcomes. So this leads me to this idea of why am I focusing on smoking cessation in cardiovascular disease and mental illness? The first two papers, they highlighted how smoking cessation could act as a key intervention to help improve outcomes for people with both cardiovascular disease and mental illness. And this then led me on to my two further projects that will take a slightly deeper look into looking at what was being offered to people in the UK by GPs for stopping smoking, and thinking a little bit about how we can incentivize more effective interventions in practice. But I'm happy to take some questions now as we take a short break.
Thank you, Dr. Wu. It looks like we've got one question coming into the chat that asks, where did you count vaping and smokeless tobacco products in these studies?
That's a great question. So they were not included. I was only looking at combustible cigarettes, so smoking of cigarettes. So they were not included in this analysis.
Fantastic.
Thank you. This is the first post. Joanne, I would like to introduce you first. So our discussion today is Dr. Joanne Patterson, Assistant Professor from the Ohio State University College of Public Health. Dr. Patterson is a behavioral scientist who evaluates culturally relevant interventions that promote tobacco cessation and harm reduction among stigmatized populations. So thank you, Joanne. You can take it over now. Thank you.
My apologies. I was so excited to jump in and see.
Yes.
And before we pop to another question in the chat, I just want to comment, as I was reading this second paper focusing on cessation and folks with mental illness, I was really fascinated in how the findings might land differently for different groups of people, especially thinking about mental health clinicians versus policymakers or tobacco regulatory bodies. And, for me, the key takeaway for mental health clinicians is this idea that quitting smoking doesn't worsen and could actually improve anxiety and depression, even among people with psychiatric histories, which really undermines a key rationale for deferring treatment to this group. For regulators and policymakers, and this is something that we're seeing some work in California happening on this side of the pond in the US, there've been, I would say the takeaway is that concerns about mental health harms from cessation itself are not really supported by the best available evidence, right? According to some of this work. And maybe we shouldn't be constraining tobacco control policy. And so should we be thinking more about how this type of work strengthens evidence for policies that actually directly affect and maybe even nudge smoking cessation among people with serious mental illness, thinking about things like smoke-free policies, right, in mental health settings. But from your perspective, I'm interested, right? This is still observational work pieces. So if we have multiple observational methods that are converging on this benefit for folks with mental health illness, issues or serious mental illness, and we're not seeing any credible signal of harm, what additional evidence do you think we need to persuade regulators, policymakers, and even clinicians to support cessation among folks that are dealing with serious mental illness?
I think that's a really good question. And I think in some ways, I'm going to pivot a little bit and say whether or not what we need is evidence, or if it's about reframing the discussion and reframing how we look at people, and if we can look at people holistically. So if we know, and we do know, how uniquely dangerous smoking is, how can we package the best outcomes for people and ensure that we're not neglecting the harms of smoking when we are looking at them as a holistic individual? So absolutely, I acknowledge if people who are working in the clinics, there's a lot to talk to the patient about. It's very hard to prioritize smoking when they are coming with a lot of other concerns. But I think of it as part of my job and our jobs as tobacco researchers and regulators is how can we get it back into that picture, that it's not an afterthought, but can we put it back in and say, hey, let's give people equal opportunities and allow them and facilitate them to make that choice, whether or not they want to stop smoking, and ensuring that, especially if we cannot continue to use it as an excuse to not provide treatment. And I don't think any more evidence will help with that, but rather it's about that conversation, and we need to be reframing and reshifting the focus on that holistic view of people.
So perhaps not leaning into policies that are nudging, but coming back and really thinking about that ask, advise, refer model in the mental health setting.
Absolutely. And I think really just acknowledging the system itself, and how can we think, and we'll think a little bit about this in the next two papers as well, of how can we prioritize behavior change, and how can we change it in terms of the caregivers, not just thinking about behavior change of the people who are smoking, but also thinking about behavior change of the systems to facilitate that and scaffold that behavior change of stopping smoking.
And I see some questions coming into the chat. I don't know if Dr. Shang, do we want to take some of those right now?
Sounds good. So one question from Norbert Schmidt about do smokers who completely switch to harm reduction products count as having quit?
Yes, so in terms of the systematic review, I did not separate by what intervention they were offered. So if I didn't, when I included randomized control trials, they were assessed by whether or not they were still smoking combustible cigarettes, yes or no. So if an individual was using, for example, nicotine replacement therapy, but they were not smoking, they would be counting as not smoking. So I wasn't focused on, for example, nicotine content, but rather I was focusing on the binary of smoking combustible cigarettes or not smoking combustible cigarettes.
Thank you.
And see, let me just jump in here. I do think it's also important for this study to just note that many of the included studies were actually taking place before this kind of modern sense of tobacco reduction and these modern non-combusted nicotine products, correct?
Absolutely, that's correct.
Thank you.
That's good to know. Thank you. Question from Amos Hausner about did you check association with the use of other addictive drugs?
No, that wasn't a part of the question. It was predominantly only looking at smoking.
The other question is, do you see any differences with women versus men in this study?
That's a good question, and I can't quite remember in terms of the data for the second paper, but I do remember for the first paper, the systematic review, we did try to do a subgroup analysis by sex, and we actually didn't have enough information on women who are living with cardiovascular disease. So one of the outcomes, or one of the implications that I did suggest, is we do need to do more work focused on women, women-only populations as well, because there were studies looking at men-only populations of living with cardiovascular disease and the impacts on smoking.
Thank you. All the questions are answered.
Great.
Yeah.
And I will say I'll cede because I know we want to dig into these two studies of yours.
Amazing. So from that, as in terms of my PhD, then I was able to kind of solidify this idea that yes, there seems to be a benefit, which I think is quite a cautious phrasing, but there seems to be a benefit for people to stop smoking. Now, for my third study, I was looking at the impact of financial incentives, specifically in general practitioners, so our family doctors. Whereas in the UK, GPs are currently incentivized to record smoking status for people living with cardiovascular disease or, for example, living with diabetes and so on. And they are offered a percentage of their wages are based on the number of times that they record for these people, whether or not they have offered or provided advice/support. Now, the most important thing I want people to take away from this is that currently the system is rewarding advising someone to quit the same as providing treatment. So essentially, they're rewarding if someone is sent a text message to say that you should stop smoking because of X, Y, and Z as the same within the system as, hey, here is an offer to a stop smoking clinic where you can get behavioral support, or they're offering it as the same level of you have been prescribed a medication that can help you stop smoking. So despite there's differences in this effectiveness, currently the system rewards the two as the exact same thing. And what we're seeing within the general population was that there is an overuse of advice codes and an underuse of effective interventions within the general populations. And we haven't seen a change in smoking abstinence rates. So what I was interested in was looking at this same question, but particularly in people living with cardiovascular disease, with or without living with a psychiatric condition. So I wanted to measure the frequency and types of cessation support in heart disease patients. And I wanted to then compare this support and success rate in patients with versus without mental illness. And where I got this data was from the Electronic Health Records, which is a GP database within the UK. And I was finding adults with incident heart disease between the years of 1996 to 2019. And then from there, in that database, I categorized the interventions into being offered smoking services referral, being offered a brief intervention, educational advice, medication, or counseling. And now, most importantly, what I categorized was not what was accepted by the patient, but rather what the GP offered. So if a GP recorded that they offered smoking cessation a referral and that patient declined it, I would still code that down as an offer given. Because what I'm most interested in and what I was most interested in was looking at the behavior of the GP themselves rather than what people were accepting of in interventions. In total, I had 158,000 participants or patients, with about 33% were being women, with the most common age group, as we might expect, of people living with cardiovascular disease between the ages of 51 and 60. Common mental illnesses, such as living with mood disorders like depression and anxiety, were about 15% of this population. And then serious mental illnesses, so someone living potentially with bipolar or schizophrenia, that was about 1.7% of that population. And the majority of people were diagnosed after this introduction of this quality of outcome frameworks, which was the financial incentives, and that was 63.9%. So what I found was, in terms of the first intervention received, the majority of our population received their intervention or their records of this intervention in year one. So 56.6% of people in this category received a code of being offered some form of smoking cessation advice or support. And then what we're seeing is up till year 5, we still have about 26.7% of this population not having any record within 5 years after their cardiovascular disease event of being offered a smoking cessation advice. Now, in terms of abstinence, as you might expect, the majority of people who do have cardiovascular disease, they stopped within the first year, but we do see people to continue to join into this effort of stopping smoking within the follow-up of 5 years. But even after 5 years, we're only seeing, less than half, just about half of people stopping smoking. It if we take a look into the percentage of codes and interventions being offered, before the incentive, we're seeing the majority of patients were not offered any intervention. So we're sitting about 79%, and then 20% got this code of counseling or education. Education being brief advice or the statement of smoking is bad for you, that would fit into that 20%. Now, after the incentive, we're seeing a big growth in this education chart. We're seeing about 71% of the codes recorded were in education. And then the next largest group is the 19%, which is no intervention, and then pharmacological and referral. In terms of what that meant on the likelihood of abstinence, what we found is if you separated out the interventions on their own, people who were offered the education, so that advice, were more likely to stop smoking, whereas prescription referral, brief, and counseling actually decreased your likelihood in these estimates of stopping smoking. But when you merge them all together, we're seeing a number of 1.41 of an increased likelihood if you were offered an intervention. This meant that you were a lot more likely to stop smoking. And if we take a deeper look into the subsections of the likelihood of smoking cessation, first of all, if we look at who's more likely to be offered a smoking intervention, we are potentially seeing, so with common mental illness, you are more likely to receive a smoking cessation intervention for common mental illness. But again, I'll talk about the caveats a little bit later. And then in the likelihood of abstinence with intervention record, again, these are people who have been offered an intervention, they were substantially less likely to stop smoking compared to people who were not living with common mental illness or a serious mental illness. And finally, the last number I want to share with you today on this paper is the idea of the number of people who were offered intervention before or after the introduction of financial incentives. They were substantially more likely to stop smoking if they had been offered an intervention before the introduction of this incentive versus afterwards. Now, we're painting us a picture where people who receive interventions are more likely to quit. However, the data seems to be showing us that the most widely used intervention, which is this education code, is what we know in terms of from other research like randomized controlled trials to look at effectiveness of helping people stop smoking, is actually the least effective for smoking cessation. Now, one of the cons of using a large database is that you get very large numbers and they can often give you very confident estimates. But what could be happening is that people who are offered pharmacological support are people who are already more likely to find it harder to stop smoking, and that could be driving this number down. So people potentially were offered advice who could have stopped smoking on their own after their cardiovascular event, and those who are more likely to use intense interventions might already be more predisposed to find it harder to stop smoking, because from our randomized control trials and knowing about our Cochrane reviews and looking at the different interventions when it comes to stopping smoking, the most effective is still within that pharmacological and behavioral support to help people stop smoking. But it also gives us this question of system level incentives, such as this QOF, potentially need to reform and consider, are we rewarding quality, or are we rewarding the presence of what we deem as support? When I know there are certain GPs clinics within the UK who will be able to right now, under the current system, send a wide text message in February, because when the end of year is March and they want to tick this box off, that they can send a text message to all of their patients to say that, did you know the best, you should stop smoking because of X, Y, and Z. Here is a link if you're interested. That would be counting as that intervention. And that leaves a question for us to decide, is that enough? And is that what we want to be rewarding in this system if we are providing a reward-based system for helping people stop smoking? Now, I wanted to take a deeper look into this idea of, if we know interventions can work, how can we get the potential gatekeepers or the potential providers to get them to offer this intervention? Now, within the UK, currently the guidance is framed smoking as a dependency which needs treatment. But doctors often hold this idea about a patient responsibility, and it will actually impact their likelihood to offer support. So doctors are less likely to intervene if they feel that the patient is choosing to smoke versus if they feel like the patient doesn't have a choice when it comes to smoking. And as one of our health secretaries a few years ago did say, is that people must take more responsibility for their own health. But that leaves the question of, what does responsibility mean? Now, if we take a quick pivot towards the realm of moral philosophy, and in moral philosophy, it's often deemed that responsibility requires two pillars, one being agency, so the ability to make a change, and the other being awareness, which is the ability to know what are the consequences of a certain behavior or of something. And when it comes to smoking as a behavior, you can start to question whether or not people have agency if you want to go into the nuance of addiction, of what does that mean when it comes to being capable of being able to take changes. But you can also take a look at the concepts of awareness of, do people really understand when they are smoking what the harms mean to their bodies? And is that harm being fully processed? And is it possible to process that when it comes to a behavior that you are doing on yourself? And if you look at this idea of responsibility under this lens, we can potentially pivot and consider, what can we do when it comes to responsibilities of caregivers and responsibilities of people providing services when it comes to helping them to scaffold this behavior change? Can doctors make a change? Do they have the agency? And can doctors have the awareness, the know of the consequences of what happens when people continue smoking? So what I wanted to ask was, can we frame responsibility, and is it possible to influence a GP or a family doctor on their likelihood of offering evidence-based cessation support? And secondly, I was also interested in knowing, what attitudes do doctors in the UK currently have regarding smoking and health? So what did I do? I conducted a between subjects online study where I recruited GPs, doctors, as well as general doctors, and students, medical students within the UK, and I exposed them to 3 different scenarios, and I asked them to measure their intention, duty, and desire to offer smoking cessation support. So the first condition is, when they were recruited into the study, they were told that they were going to see a tweet about policy, and they would be asked them questions afterwards. And what we're seeing on the screen right now is my condition of my control condition. So the first sentence stated that newest research reaffirms that the most effective way to help people stop smoking is through behavioral support and/or medication. GPs should give all patients smoking cessation support. My first experimental condition, I had the exact same first sentence, and the second sentence is where there was a change. This is where GPs should remind patients they need not quit on their own and offer patients smoking cessation support. So the idea of what we were trying to target with this is that responsibility and who that is being shared is between both the patient and the clinician. And finally, this idea of professional obligation, where it is a GP's failure to provide a patient with smoking cessation support is a failure to meet professional obligations. And this is all hinting on the concept of what is responsibility in terms of agency. So we're sharing the idea of shared responsibility is shared agency, potentially, as well as this professional obligation is meaning that it's a failure to meet your obligations of your responsibilities because you meet the conditions of having awareness and having agency. So our participants were recruited, and they saw one of the 3 frames, one of the 3 fake tweets. They were then given 3 scenarios where they were seeing patients, and this was where they saw an idea of a patient, and they were asked what would they do with this patient. And we had the context of illness, which was in cardiovascular disease, serious mental illness, and a non-smoking illness such as sprained ankle, as well as a context of consultation. So a computer record prompts you, there's time constraints, so you're running behind, and you know that the patient previously has mentioned no motivation to quit. So this is what they saw. One example being, your patient Sandy has come in to see you about a sprained ankle. You're confident that they will recover swiftly. Their records indicate that when they last visited the clinic, they smoked cigarettes. And then the participants were asked to rate on a scale from strongly disagree to strongly agree whether they felt the they ought to offer, whether they wanted to, and whether or not they intended to offer this patient smoking cessation support. So as we can see here, the flow chart is participants were recruited in, they saw one of the 3 frames, and then they saw 3 scenarios, and this was randomized, and they had I blocked them so that each permutation of the different scenarios was shown, but each participant only saw 3 scenarios that they had to answer, and they followed up with a questionnaire at the end. So what did I find? The majority were aged between 18 and 44, predominantly female, and the majority of my participants had never smoked, nor had do they live with someone who is smoking, and that they were mostly general practitioners or family doctors. So what I found was that through running a linear regression, that framing had no effect on desire to offer support or this idea of duty to offer support, but professional obligation the frame was associated with an increased intention to offer support. However, when we look at bringing into the mixed effects, so the effects of the context of scenario and the context of illness, we are seeing predominantly that the variation was potentially coming from heart disease, so the context of scenario. So people were a lot more likely to have a higher score of desire, duty, and intention when the scenario they saw was of someone living with heart disease, the same with someone living with bipolar. And we did continue to see an effect from professional obligation on an increase in intention. And in terms of what my population was saying in terms of what they believed, here there's a lot happening on the screen, but what I want you to focus on predominantly are these 2, is that the majority of my population agreed and said, somewhat agreed or strongly agreed, that smoking is a lifestyle choice, while at the same time agreed that addiction is a disease that requires treatment. It gives you a question potentially of what does that mean when within a few clicks away, they're both saying that smoking is a choice, but also addiction is a disease. And what does that mean when it comes to policy, and how can we shift the way that we can think about smoking when it comes to helping people stop smoking? But that leaves me to the implications and thinking a little bit wider about what is next and what does this mean. It means potentially that people want to help people living with cardiovascular disease. This is great. They think that people living with cardiovascular disease and people living with serious mental illness should be getting smoking cessation support. But the reality is within the UK, they still aren't getting at the targeted rates that we want them to, nor are they getting the interventions that we want them, that we know as researchers and as policymakers know are to be more effective. So what can we do when it comes to shifting that argument and shifting that conversation to ensure that what is being offered is actually effective for people? It doesn't matter if a medication is useful if participants or if patients can't get their hands on them. So how can we generate that conversation and think about it from a systems level of how can we change the system to ensure that we're facilitating behavior change, both from a systems level, but also from an individual level. And I'd like to just thank very quickly my 2 supervisors, Jamie, who is here with us today, as well as Nicola Linson, and the wider Oxford Tobacco Addiction Group for all their support during this work, during my PhD. And I'm very happy to take any questions right now.
Thank you. Thank you, Angela. Let's turn to our discussant first, Dr. Patterson. Please take it away. Thank you.
Sure. Thank you. So Dr. Wu, I really appreciated your first paper thinking about interventions in the clinical setting. And, you know, this paper is really fundamentally a question or a paper that asks the question about how effective are the systems that we currently have in place for encouraging cessation, right? And your findings really demonstrating that the recording of cessation advice in the electronic health record isn't necessarily translating into delivering these most effective evidence-based cessation support interventions or equitable quit outcomes if we think about the outcomes for folks with mental illness. So you raised this question about quality and in your implications section, and I'm wondering, so in your opinion, If policy incentives are successfully changing coding practices, but not quitting, how do we redefine this metric that we might have in the EHR to capture quality? What does quality look like?
Yeah, that's a really good question. And I think it's a kind of question that it's very easy for me to say. I could say, oh, we should be assessing it as the most effective interventions and only if they offer these interventions. But we also, as a system, don't want to be prioritizing the idea of prescribing or the idea of unnecessarily, for example, if the tick box is that only if they are offered a pharmacological intervention, and who gets to make that decision as to which of the interventions are the ones that fit into it. So I completely see the difficulty in how can they do this system of reward based, but then it gets to the further question of should we be doing a reward based idea of trying to get them to do anything when it comes to recording? Is there a better metric? And I think that's a hard question, and I don't know the answer. I don't think it's something that is something that from my research that I'm able to turn around and say this is the answer. But I think it's the discussion of how can we ensure that the patients are part of that conversation. That's what I really want to bring back in, is the idea of GPs don't have to wait for people to come into the doors and say, I want to stop smoking, to only then offer. I want that to be reframed, where we are actually getting doctors and the system to think about it's okay to ask people whether or not they would like to stop smoking, and having a comfortable conversation where if they say, no, I don't want to, you're very comfortable to say, okay, that's fine. But also have that conversation of, hey, maybe someone today is interested, because people's day-to-day motivation can change when it comes to smoking cessation. So how can we reward the system to ensure that doctors are starting that conversation is more important than what they offer, is what I believe. But it's about that quality of that conversation.
And given what you are acknowledging about people's context changing in the moment over time, repeat engagement also
Absolutely
emphasized.
Yes, exactly. Someone today might say no, but then next week they come back, or in 2 weeks they come back and they're actually like, yeah, you know what? I am interested in hearing what you have to say. And maybe another month down, they're ready to start something. But it's just about that idea. And I like to pull it back to that moral philosophy of thinking about responsibility. We live in a world today where we're often told that we have responsibility over ourselves to take care of ourselves. But we also live in a society where we're completely reliant on one another, that we can't completely negate the impact of society and the impact of how we owe one another and what we do with one another. So how can we kind of bring that back in when we're still trying to, of course, let people make their own decisions, but can we ensure that we're allowing to scaffold that decision making and people know what options are there?
Mm-hmm. Well, and we know when we think about people's readiness to quit, right, that multiple touches in multiple ways in order to be able to understand information, make decisions, and change attitudes. So, I love that you brought up this text-based option that providers have, even though that might be negative if what we're just giving is education. And we have a comment in the chat that I just, or the Q&A that came up that I just wanted to make sure I highlight. Lisa Sloan said, wild idea. What if providers got a text message when one of the patients have quit? Providers rarely see cessation results. What do you think about that?
Yeah, I really have to, clinicians have a hard job where they see so many what we might call failures. And it's not fair to call it failure, but smoking is often seen so binary. And we know that people take multiple attempts. If someone wants to stop smoking, I think on average, it takes 30 attempts for someone to stop smoking, to successfully stop smoking. It's demoralizing for GPs and doctors as well, of why should I continue to do something if I'm not seeing effects, if I'm not seeing that? And then, yeah, maybe that would be a great way of bringing back in this context, especially bringing back in we are a society. I care about you, you care about me. What I'm doing has an impact on our patients. It's just about seeing how can we make it work in today's landscape.
I know one of the things we're seeing here in the States, referral to the state quit line is one of the practices that we are encouraging as evidence-based practice in the clinic setting. And we have some hospital systems that have been trying an integration in the electronic health record with the state quit line. So they can do an EHR referral to the quit line and then get data back about whether someone engages with that quit line. It would be interesting to see a study come out that's looking at those outcomes and how that's influencing even coming into your second study. Does that influence physicians' attitudes, right, towards patients and how they're reviewing cessation and smoking?
For sure. I think within this landscape to remember, though, because how uniquely dangerous smoking is, and maybe that's a very naive researcher perspective to take, if one person stops smoking, that is a win. And there's great health economist modelers, and they will run the analyses. But because of how uniquely dangerous smoking is, if we're able to do anything that is able to shift and get more people to stop smoking, provided that they still have choice and agency to do what they want to do. I by no means believe in a world where we should be forcing individuals to do anything, but I do think we need to also facilitate a society where we're able to talk about these conversations in a positive manner and allow people to have that choice to make.
Yeah. Well, and I don't think that's naive. I mean, granted, I have a bias as a tobacco harm reductionist also. So, and I'm wondering actually, given and then actually before we go there, I think maybe there's a question in the chat we should probably answer.
Oh, sure. Yes. So there's a question from Lei Xu and wonders how much of the recorded smoking cessation reflects what actually happens in reality as opposed to what gets documented because of the incentive structures.
Yeah, so that's a really good point. I would say that there isn't any incentive that I know of that is to actually do with performance-based. So it's not to do with whether or not people stop smoking. So there's no incentive beyond an individual who might, in that moment, say to their GP, I have stopped smoking. That individual reaction, but there isn't on a system level where GPs are incentivized to record people as stopped smoking versus continuing smoking because there's any points to that.
Thank you. And also, audience, please keep your questions coming through the Q&A panel. If we don't have a chance to get to our questions, or if you'd like to discuss with the speaker directly with mics enabled, you're welcome to attend the Top of the Tops immediately following this webinar. If interested, please copy the meeting room URL posted in the chat now, so that you will be ready to join the live discussion once this webinar concludes. Thank you all. So, and Joanne, if you have any additional questions.
Yeah, I just have one last question that comes back to this kind of naivete question and, kind of speaks to my bias as a tobacco harm reductionist. But I'm really fascinated with this clinician moral ambiguity, right? That many of us hold, right? Seeing smoking itself as both a disease and also a lifestyle choice. And I'm just wondering now in this modern context of tobacco harm reduction, how this moral ambiguity might shape clinician openness to switching to, non-combusted nicotine products rather than insisting on abstinence. And I'm just wondering your thoughts on that.
Yeah. The idea of first do no harm and how, especially, within the UK has taken quite a strong approach compared to the rest of the world when it comes to using e-cigarettes as a smoking cessation tool. Within the UK, the NHS, our health provider, will offer you an e-cigarette to help you stop smoking cigarettes. Now that is very different compared to the rest of the world. And when I talk to local city councils and providers, when we're trying to think a little bit about their own locality, I do get into this discussion of, well, aren't we told to first do no harm? How can we know if this is doing no harm? And I tend to kind of shift that conversation to talk about, well, what we do know is uniquely how dangerous smoking is. And what we do know in the UK right now, there's a big discrepancy in who is stopping smoking and who is continuing smoking. And we also know within the UK, of the people who are living, for example, with a lower socioeconomic status or living with financial hardship, they are significantly more likely to view that e-cigarettes are more dangerous than cigarettes. And that, in my mind, is quite a dangerous position to be in from a policy perspective, of if the people who are most likely to be smoking within your country are also the people who believe one of the avenues that the country has decided as your harm reduction tool is more dangerous, what has happened in our messaging when it comes to offering that? And how can we, when it comes to talking to our providers, is it something that we providers are saying that are causing people to feel a certain way? Or is it what is happening within the infrastructure of just communication of harms? What does that mean? So I don't know if I'm really answering that question of how can you shift, but I think it's always going back to the big picture of remembering how uniquely dangerous smoking is. And the goal is always to help people have a healthier lifestyle. And I do believe when researchers, and they're not funded by the tobacco industry, they're not going in with the agenda. Most of us come here with the aims and goals of helping people to live healthier, happier lives. How can we all reach that goal together and ensure that we are still looking at the long-term harms of e-cigarettes and we're looking at the long-term effects, but that doesn't stop us from helping people in this moment who might be able to shift from a cigarette to an e-cigarette and then potentially go down to another reduction tool, or versus the idea that you must take something that we know is potentially effective, for example, potentially NRT or varenicline or bupropion, cytosine, and so on. But if that doesn't feel like a realistic choice to them, who are we to say you're not allowed to choose something else that is likely to be less harmful?
And both ends still having that conversation about complete quitting of
Absolutely
products, when the patient's ready. And I would just say, and this idea that it's especially important for those groups that you're interested in, not being able to necessarily to speak to the demography in the UK, but at least here in the US, that intersection of low income and serious mental illness and CBD events, I'm assuming is the same in your part of the world.
Yes, exactly. And it creates this level of urgency. I feel this urgency of how can we start thinking about this framing of we don't get lost in our worlds of conversation, and we focus on the outcomes of people and helping people and putting the people who are living through this at the center of what we are doing, rather than the wider discussions, the political discussions about what the evidence and where the evidence is coming from, and really just making sure that we're applying this with a sensible mind and ensuring that we're answering the right questions and remembering we want to help people stop smoking and reduce their risks of dying. We want them to live healthier and happier lives. And how can we get them there in a way that they want to do that? Because at the end of the day, we cannot dictate what people are doing, but we can help to have those opportunities and truly have those opportunities there, not a fake opportunity where you say, well, we've offered you a text message that is sufficient, but rather actually offer a true meaning when it comes to that opportunity.
Thank you so much for this conversation and for inviting me into it.
Thank you so much.
Thank you all for the great discussion. I think we're about time, and we have top of the tops following this. So I'll let Mike take us out. Thank you.
Thank you.
We are out of time. However, if you still have burning questions or thoughts for Angela Wu, you can join us for Top of the Tops, an interactive group discussion. To join, please copy the Zoom meeting URL posted in the chat and switch rooms with us once this event concludes. We'll leave this webinar room open for an extra minute after the end to give everyone a chance to copy the URL, which is bit.ly/topsmeeting, all lowercase. Thank you to our presenter, moderator, and discussant. Finally, thank you to our audience of 150 people for your participation. Have a top-notch weekend.